it's a very big screen, so I have to move a little bit because otherwise I cannot read my own slides. But I thought it would be nice as a neurologist. I see a lot of patients with traumatic brain injury. I see them at the emergency department, I see them at the ICU. I have an own outpatient clinic, so I see the patients in the whole chain of care. So I thought it would be nice to have 3 parts because an hour is very long. And the first part is about figures and facts about care. The second part is about research. And the third part is about challenges in care and research. So I hope then to provide you some more background information on mild TBI. That would be the idea of the presentation. And for those of you who do not know where Groningen is, it's in the most upper part of the Netherlands, and we have 9 level 1 trauma centers, and Groningen is one of them, and we also have a helicopter situated, so we also cover the northern of Germany. So we are really involved in all types of brain injury. And our hospital has around 1,000 beds. So first about figures and facts. What do we know about mild TBI? Well, a lot of people have traumatic brain injury. And the figures speak for them, and alone in Europe we have 2.5 million patients per year, which is a huge number. And most people get a mild TBI. So the attention in public is for the severe ones, but in fact, and most of you also, I guess, see the mild ones, because there are tremendous numbers who sustain a mild TBI. And it's good to know that 1 in 4 patients has residual complaints, and they interfere with resumption of daily activities. So it's really also high related health costs. What happens when a patient is seen at the emergency department? What is the chain of care? Well, most people are just go directly after discharge to their home. Some people are admitted to the ward, and sometimes they go when there are a little bit more injuries than they had, they go for rehab or to the outpatient clinic. And we have looked at those figures from the last 10 years in our hospital. So these are figures from our own hospital. And what we found is that around 88% go directly to their homes, and 1 in 10 patients need some additional care from rehab because of fractures or those kind of things. So all people return to their home. That does not mean that their outcome is favorable, because we found that almost 1 in 4 patients shows incomplete recovery, which is quite a huge number. So that's why I cannot translate it in English. It's a wolf in sheep clothes. It's some kind of comparison we make. Maybe you have the same in Denmark. Okay. And what we also did is we looked at patients who were just directly discharged, not after admission, and how many of those patients return because they have persistent complaints. And we looked who saw them. Was it a neurologist or the surgeon or the rehabilitation physician? And we found that a lot of people return because they have persistent complaints. Only the problem is, in our healthcare system at least, it's very difficult when can they return, what does the general practitioner, and so we're currently thinking about it, how to see them early, but also who has to treat them? Is it a general practitioner, or do we have to refer them directly to the hospital? We are not sure about it yet. So this is one of the challenges too. If people return, they have a lot of complaints. Cognition, behavior, well, there are some examples: forgetfulness, concentration, fatigue, but also lack of overview. They have planning problems. And sometimes for patients it's even difficult to explain which complaint they have, because it's all mingled together, all those complaints. But the result is they do not function very well. And you will find it in work resumption, but also in traffic participation, for example, relations, social life. And it depends on the severity of injury. So the severe ones is quite clear. They cannot work or they cannot drive a car. But for the mild ones, it's more subtle, because then you don't have to ask whether they participate in traffic, but they do. But you have to ask whether they are able to drive for an hour in a car, because that is a higher cognitive function, and they have difficulties in maintaining the concentration for driving an hour in a car, or just making a meal and just having a dessert and a meal and also some things before the meal. Then they say, no, I can just do one thing, but I'm not capable anymore of preparing a big meal. Or, for instance, if you have a meeting on your work, okay, they can do the work, they wear a headphone, but if you have a meeting with your colleagues, it's very difficult to be the leader of the meeting. So it's more subtle in the mild TBI patients. And what you can do is you can rate all the complaints they have. You have a complaint list and you look at it over time. I did it on purpose because this is too much information. We do it every time we see a patient, we let them fill out a questionnaire about complaints, but it does not give you that much information. Okay, it decreases over time, but what I did is I then looked at the top 5 complaints to see what is important, and then you get more information, because if you look at the top 5 complaints over time, then you see some kind of pattern. Because if you look early, then there are more physical complaints, headache, for example, but also some complaints about concentration. Irritability is a little bit vague. It's about irritability, concentration. But at 12 months, then you can see that the dizziness had disappeared, which is really a more acute complaint. But people still, they also still complain about concentration, but more in relation to forgetfulness. So it gives you an idea how complaints can change over time. Another thing is, if you look at persistent complaints, then you can see fatigue is a complaint which is there from the beginning to the end, and also concentration is there from the beginning to the end. Only by patient it is perceived otherwise. So in the beginning they talk about headache and irritability, and later on they talk more about forgetfulness and headache. So it can give you some clues in the treatment of patients. And I always say to the patient, it's about brain filtering. In everyday world there are a lot of stimuli, and you have to block them sometimes, and sometimes you have to let them in to achieve your task, and even to achieve more than one task. But if you have just had that injury, you have difficulty with the brain filtering. And people complain about concentration, and that's what makes them, but still they can achieve their task. They are not intellectually disturbed. So it means that they can do a task, but they can do not multiple tasks. So it's about brain filtering and multitasking. And that's how I explain it to the patients who come in. So the question, of course, is which factors determine outcome of these patients, and can we find them at an early stage? That's part of the research questions. And then you have to realize that there are several areas you have to take into account. The severity of the injury, but also the kind of injuries the patient perceives. Is it on the behavioral, the cognitive, or the physical domain? And also patient-related injuries. How old is the patient? What is the education? But also some personality factors. And I'll dive into this a little bit more. And for the factors regarding personality, I want to say one thing, and that's when you compare mild to severe TBI patients. In the beginning, mild TBI patients have more complaints, and they are also more anxious and depressive, which you can see in those 2 slides. And so if you think about mild TBI patients, it's also about perception of illness. Whereas in the severe group, it's more about awareness of illness, and they really have deficits, so they really have problems in the awareness of their illness. But the mild TBIs have a higher perception of their illness, but also of their complaints, and maybe that's related to being more anxious and more depressed, having more emotional distress. And of course, that's a very short slide. Impairments are on the physical, the cognitive, and the behavioral domain. And you have to realize that also in mild TBI, they have the same kind of impairments, only at another level. So when you talk about behavioral problems about disinhibition, it's about, in severe TBI, it can be about being very unreasonable, from shouting to whatever. But in the mild TBI bounds, it's about more subtle things, about behavior not behaving within the social context or being more emotional. So even in the mild TBI, of course you have behavioral problems, but on a lesser level. And if you look at severity of injury, I think there are two things to take into account. That's the indirect measure of post-traumatic amnesia and imaging. And post-traumatic amnesia, when you get an accident, you experience a short comatose state, and then there is a problem with retention of memory. And sometimes people cannot remember a few minutes or hours before the injury, but they also have problems in retention of current events, and that's called post-traumatic amnesia. And post-traumatic amnesia can vary from minutes to hours to days. And we know from research that PTA, the duration of PTA is associated with outcome. So it's always good to ask patients what the first moment of recall was. And for patients, there is no difference between coma and post-traumatic amnesia, but at least you have some kind of timeline. What about imaging? Well, that's more not complicated, but you have to realize that it does not help you always, imaging. Because if patients sustain injury, you have focal injury, which is because of the 𝗪𝗪𝗀𝗪𝗪 mechanism in which the brain touches the skull base, and you can have focal injuries, which is depicted in the left picture here. That's a focal injury from related to a 𝗪𝗪𝗪𝗪𝗪 mechanism. You can also have diffuse injury. And you can see it here on the upper side, if you have diffuse injury by rotational forces, then the nerve branches get torn and you get axonal injury. And this one is maybe a little bit complicated, but it shows the brain. And here in the places are the brain are the most rigid places. And the rigid places are very vulnerable for rotation. There is where the sharing occurs and the damage. So these are the places you see the axonal injury. And the higher the impact, more deeply in the brain, you see the hemorrhages. So if the impact is not that high, you see it in the cortical surface. But if the impact is high, you see it here within your brain or even in the brainstem. And that's related to having impairments. So that's about axial injury. But you do not see very much on the CT scan, so it doesn't help you. And most people have a combination of injuries. So that's why we increasingly use the MRI. As you can see here, these are two CT scans. In 8 to 10% you see abnormalities. This is not that high, but in those patients who have a normal CT, 1 in 4 patients show abnormalities on the MRI. So it could help you to see structural abnormalities. This is an MRI. And you can see that especially the MRI shows abnormalities at the base of the skull, which are not detected by a CT scan. So that's one advantage of an MRI. And the other advantage is that you can find some products of blood, of sharing, which is blood, with MRI, with a new technique. And that can also give you some information. And this is another example. On the left side, you have the CT scan, of which you would say, okay, it looks quite normal to me. But with the MRI, you can see the degradation products of blood, which appear as black figures. And here you can see black figures. You can see them here, but also you can see them here. So if you only make a CT scan, you say to the patient, go home, your CT is good, everything will become good. And if you make the MRI scan, you might think that the patient could have some problems. And this is another picture which is a little bit bigger, and then you can see this is about sharing injuries here. And you can imagine that this patient has some cognitive problems. However, MRI is not helping you for definitive conclusion about impairments and functioning, because lesions it's difficult. How many lesions are important? Everybody from you or in the audience maybe has 1 or 2 lesions. It's not that important. So it's about the number of lesions, and it's about the regions they are in. So or you have to have lesions in multiple regions, or for example, the temporal lobe is most vulnerable for having lesions. So you have to weight it, and also you have to weight it with the neuropsychological assessment. So it's not, sometimes insurance companies think, okay, we just need an MRI, and if the MRI is negative, that's it. No, that's not true. You have to look at the patient, but also take the neuropsychological assessment into account. So this is the first part about figures and facts, and maybe this is a good moment to see whether there are questions. Yeah, I see one hand. Right.
Thank you very much. It's very, very interesting. Do you test the injured person's personality? Any kind, or is it just
Because these are just facts, and of course the question is, what are determining factors for outcome, and how comes personality into account? Yes, I'll dive into that in the second part. Yeah.
those MRI scans, when were they taken?
Well, most of the time it depends on what your chain of care is, but in my outpatient clinic I see them first at 6 weeks. I see whether they have complaints, whether they have resumed their work. Then I'll see them back at 3 months, and if they still have problems with that, then I'll do the MRI. But I know that there are centers who perform them earlier, but well, my idea is that a lot of people also recover. So I do not need an MRI in every patient, but I want to do an MRI in those patients who do not fully recover. And that needs some time to discover that.
So we often have patients who get the MRI scan maybe after 12 months and nothing is seen. So, if
Yeah.
I understand you right, those were minor bleedings.
Yeah, well, there is discussion about that because it's a very sensitive method, but if you compare it longer over time, then you discover less abnormality. So they can stay there for years, but still you see less abnormality. So it's not staying there forever, those abnormalities. No.
So there might have been a bleeding early on, maybe in the acute phase, and you can't see it after a year.
Yeah, but bleeding, I mean, it's about microhemorrhages. So, and they are diffusely through the brain, and maybe you can not see them all, but still then if there are a lot of them, maybe you see some focal atrophy in the end. So maybe after time you have to look at other signs on imaging. That's also a possibility.
Could I comment on MRI?
I think it's Toril who is saying something, but I don't see her. Where are you, Toril? Oh, there, yeah. Yeah.
I'm a researcher from Norway, and we have performed quite a lot of MRI on a sort of more mild sample of concussion, where we also recruited a lot of patients who are not in the emergency department in a hospital, but only in a GP or an ED. And we actually took MRI at as soon as at 72 hours, and with very good sequences, long MRI protocol, 3 Tesla, and we found the different numbers and what you show. It's very much about the setting, what kind of concussions are we looking at. So we only found 5% with imaging, with MRI imaging, when CT was negative. So it's really much about the setting, and so that makes me really agree with you that there is no reason to stress that with performing MRI really early in everyone. That's not going to be useful. So I don't know if you agree with me in that.
Sorry, I did not understand the last sentence.
Do you agree with me? I guess you agree with me in that that the really common, uncomplicated concussions that not
Yeah.
even.
Yeah, so
We see a lot of those in our clinic that they haven't necessarily been into the emergency department in the big hospital.
Yeah.
So then the likelihood of catching something on MRI is really low.
yeah, so yeah.
To be stressed about the
Yeah, I agree.
rushing to
Yeah,
MRI.
so we agree that it has not to be part of your routine assessment. It's not. No. Okay. Thank you, 𝗲𝗲𝗿𝗀𝗲𝗿𝘆. I'm glad we still agree about this assessment. Maybe I can go further now with the research part and the personality and the influence of personality factors. I decided to share with you some information on the upfront study we did, because I think it's still valuable to the results of that. And the question is how to predict the outcome, because you have an injury. We know something about the influence of demographics and something about personality factors, which means we have the Glasgow-Coma scale. We look at CT abnormalities and post-traumatic amnesia. We look at age, gender, education, for example. And we look at emotional distress and mental health, and especially previous mental health. But it is good to know that most patients have a maximum GCS on the emergency department. It doesn't help you. 10% at most have CT abnormalities. PTA is often not documented. What about elderly? We see them increasingly. Does those account these factors also for the elderly? And how to determine personality factors at the emergency department? Patients are confused, they have headache, and they want to go home. So it's quite a difficult situation. So with that in mind, we started the upfront study, which contained a follow-up study for 1 year with timeline. We saw them at several time points, an imaging study and an intervention study, and I'd like to share some information about the follow-up and about the imaging. We included a lot of patients in the age from 16 till 92 years. And what we did find is most injuries were caused by falls and traffic, which is quite well known. Within that group, we also saw a lot of bicycle accidents. Okay, but that's a subgroup, but that's a trend also. And yesterday in the Netherlands, it was of the day of the bicycle helmet, which is a national day in which we want to promote bicycle helmets. To be honestly, I don't wear it yet because I think we have to define risk group factors, which means younger people or all older people with e-bikes. I don't have an e-bike, so far I don't wear it. But then you know what we are, the current trends in the Netherlands. The people, you see that complaints are common in mild TBI. So you see that in the right figure, a lot of people have one or more complaints even after 12 months. A portion also experiences emotional distress. So the question is, what is the relation with complaints and distress? And the other thing is, so you have to realize that every complaint does not result in incomplete recovery. So maybe this is also an indication of, it depends maybe on the personality, how to perceive complaints and how to relate it to functioning. That's the... What we also did find is that around 1 in 4 patients do not resume their work, study, or previous activities. So that's less than the people who have complaints. And if you rate outcome on the Glasgow outcome scale, you find around 45% is incomplete recovery, which seems a high figure. So what we did is we aimed to predict outcome based on factors determined at the emergency department or later on. And what we did is we looked at factors at the emergency department, in which we looked at age, gender, education, Glasgow-Coma scale, PTA. And these were the factors that were within the model, these ones. But then we added some personality factors or emotional distress. But we determined that 2 weeks later, because that's a better moment than do it at the acute moment, what I already mentioned, when the patient has pain and wants to go home. And what we did find is that in the ED model, these blue ones are the factors that are related to outcome. And if you look at the ED plus model, then you find that these factors are relevant for outcome significant, but not age and gender anymore. So there is some change if you take the personality factors into account, and we found that passive coping was negatively related to outcome, and the funny thing was that avoidant coping was positively related to outcome. So that was an interesting finding. So we concluded, and of course it's a short conclusion, I cannot go into detail in that, but we concluded that personality factors, how a patient reacts to the injury, is important. And this cannot be determined in the acute moment of injury. So somewhere after injury, you have to determine personality factors. We also did some imaging studies, because that's not all, of course. Patients ask, but what happened to my brain? It's not only the psychological or the personality factors, but what happened with my brain? We did fMRI studies, and you have to realize in your brain there are a lot of areas working together. We call them networks, and the networks work together on special tasks. And if you and we gave our patients a cognitive task, and if you get a cognitive task, then you can see some areas are highlighted. But even if you are in a rest condition, your brain still is active. So the upper figures are in a rest condition, and this is figures about in a task condition. And so the brain has to switch from a resting condition to a task condition, to put it simply. And when we gave that cognition task to patients, then we found that patients without complaints could switch easier between the resting and the task condition. And there were also less efficient results if patients had more emotional distress. So something happens to your brain, it's even influenced by having more emotional distress. So that's an interesting finding. We also found that that effect was most clearly present at 6 weeks, and it disappeared at 3 months. So something happens to your brain, but it looks at if that's temporarily. So that you can also say to patients, so there happens something to your brain, and it's temporarily, but if your complaints remain very high and very long, you also have to look at personality factors. So that's my explanation to the patient. So what we did find is, we find in mild TBI, you have to look at neck pain at the emergency department. You have to look at GCS PTA, education, but also at personality factors. So the message could be, both severity of injury and complaints are important. Brain networks collaborate less efficiently, at least temporarily, and you have to take personality factors into account. So that's the second part about research. Of course, there's much more to say, but I thought I would focus it on that. So, are there any questions?
Hi, thank you. I was considering if you, since the study in 2017, have considered other factors that could have gone into the model, also both personality factors, but also like physical factors to this group.
Yeah, well, that's an interesting thing, because nowadays I see more patients who complain about visual disturbances, about dizziness, about balance disorders. So there is discussion going around, are people more aware of complaints, or is something else going on? I'm not sure, but I think the problem is, we looked at physical factors at the emergency department, neck pain, but also headache, and we only found neck pain. You can imagine that part of the, when your head and brain is moved, it's kept in line by the neck muscle. So you can imagine that neck pain could be a predictive factor. So I think I'm not sure whether I can find those physical factors, but I'll tell something about in the last part, because if you look at symptoms in symptom profiling and you look at physical symptoms compared to cognitive or behavioral symptoms, maybe that can give you a clue for treatment, but I'm not sure whether I already can detect them as predictive factors already that early after injury. Yeah, I think that's my answer. I saw Toril.
Your MRI study is really great, I think. But in the people who kept their symptoms, or where the symptoms are upheld, did they also have a normalization of the connectivity?
Well, the problem is on fMRI you do a lot of results on group level. So the results are on group level, and I cannot precisely answer whether there are a few patients who had still, I'm not sure, we could look at it, but I know only the results on group level. Yeah, yeah. Some other questions?
Did I understand that you just mentioned visual problems just now? My question was to the first part of your speech. You had this list of all kinds of symptoms, and I was wondering if visual problems was a thing that you had ruled out, or this is something that you don't find?
Yeah, well,
why it's not on the
it is we now added it to our list, so that's one of the reasons it's not on the top 5. No, but these are the figures from a cohort from 2010 till 18 or 15, like something like that. So that's why it's now not on the list. We have it now on the list. But it's a difficult thing, because it's about blurred vision, double vision, it's about convergency, and I know some research is going on about that. But if you do some additional diagnostics, most of the time you do not find signs that there is some disturbance in the brainstem or in the, so it's difficult to grasp those visual disturbances. But we still rate them, yes. Yeah. Okay. If there are not urgent questions anymore, then I'll move to the third and last part, challenges in care and research. And I want to share 4 things with you. There are changing demographics. 1 in 4 patients is 60 years or older, and that number will increase. So it's important to realize there are more elderly people. The other thing is that we have insights, more insights in the pathophysiology from recurrent TBI, from sport concussion, which underlines the role of inflammation. So I want to share some information with you about that. There are increasing possibilities, diagnostic possibilities, imaging, serum markers, whatever. So what to do with it and how to incorporate them in care and research. And the other thing is about personalized treatment. Is it multidisciplinary, or have you go to more targeted treatment? And then I think you have to think about symptom profiling and ID of at-risk patients. So first, in the upfront study, we looked at the quality of life of elderly people 12 months after injury. We were just curious, how do they perceive the quality of life? And why is that important? Because elderly people are different. They have more fall-related injuries. By that, they have more CT abnormalities because they use more anticoagulants. But they also have more comorbidities. So the state before the injury is other than the younger people. So first we looked at quality of life. And the interesting thing was that, well, has a little bit shifted, but overall, elderly people, they perceive the quality of life is good to very good. Keeping in mind that half of them experience incomplete recovery. But the overall quality of life, it's experienced as very good. The other thing is that if you look at those patients who have incomplete recovery, 1 in 3 experience their quality of life as good. And it's called the disability paradox. So even if you have incomplete recovery, all the elderly people experience their quality of life is good. Well, there are a lot of things to say about that, of course, and currently we are doing the Reconnect study, in which we have included around 150 patients. And there we will look at not only at quality of life, but also at needs, because I think elderly people have different needs. They are dependent maybe more on their social structure they have. So maybe within 1 or 2 years I can tell you more about that, about elderly and their outcome and about needs. It's not an invitation to come back, but I'm very curious about what it will tell us. But I think it's good to keep in mind that elderly people are different. And the other thing is, of course, which we also know, is that what kind of outcome do we use? GOES has a ceiling effect. And we know, which you can see in the right slide, that even patients with good recovery according to the GOES have some physical problems and behavioral problems. So the GOES is a very raw measure to measure outcome. Even in patients with a maximum GOES have executive functioning disturbances. And symptoms, we use it because people have symptoms, but we know that they are non-specific. So we really have to think about multidimensional outcome, because this is not good enough to talk about functional outcome with the GOES. But you can compare studies with others, so that's why everybody uses the GOES. So if you look at the picture of outcome predictors, at the right side we have outcome. We have at least changed that by multiple outcome measures, and we have to look at elderly people, how to take them into account. So that is the message of this slide. Another thing is what I want to talk about is the role of inflammation. There's a lot of research going on, especially in the United States, but also here, for example, in ice hockey players in Sweden, that a lot of people in sports injury have subconcussive impact. They are not really unconscious and they don't have PTA, but they have recurrent, repetitive microtrauma. And not just I've hit my head 5 times a year, no. For example, football players, they have microtraumas hundreds of times per year. That's what we're talking about. And what happens with microtrauma is that these are repaired by microglia activation. But the idea is that if you have a lot of microtraumas over time, then this repair process is not good enough, and then it could lead to chronic inflammation. That's the theoretical idea behind it. And this could lead to post-traumatic complaints, dementia, even to chronic traumatic encephalopathy, which I will not dive into now, but that's the idea behind it. So there could be an entrance in the acute phase on the role of inflammation. And last time some interesting papers have appeared, and I'm glad I also cited Torrell, so she cannot ask a question about that, I think. Just to summarize, you can determine those in serum. And what we found is, and you have a lot of inflammation biomarkers, interleukins, for example, so this is too much detail, but it's good to realize that you find increase of those interleukins up to 45 days after sport concussion, and this is then an example of that rise in the red color. We also did, from our group, a systematic review, and we found that there is a prognostic value. It seems to be associated, some of them, with CT abnormalities return to play on neuropsychological assessment, so that's an interesting finding. And the other thing is that there is an association with MRI abnormalities. So something is going on in the brain, which you maybe not always can detect, but we have to think about that. We can also, with new diagnostic, we can find some signs of inflammation, indirect signs, which is with MR spectroscopy. You place a voxel in a region in the brain, and within that voxel, the brain metabolites are determined. And you have some metabolites which represent inflammation or oxidative stress of energy, and not in detail, but there have been found some disturbed patterns in football players, but also in soccer players. And that's all related, the idea is, to microtrauma. You can also do a PET scan. In a PET scan you inject a ligand which is connected to some region in the brain. And we have a ligand which is called CPK11195, and that's the upper slide on the right. And there is uptake, and we also found uptake in kickboxers 5 to 10 years after stopping with their games they did. So that's an interesting finding. And Marklund, which now I have to be sure, I thought he was from Sweden, and he did some interesting studies with ice hockey players, and he coupled it, and he also found a relation between the increase in CKK and tau, which is a marker of neurodegeneration. So all those sport-related concussions, they are just searching for inflammation and the relation between degeneration, because so far that chronic traumatic encephalopathy is a pathological diagnosis, and researchers are in search for signs of inflammation and degradation at life. That's the current trend. And there are a lot of diagnostic biomarkers in blood, even in saliva imaging we have, and there are a lot of studies about biomarkers of cell damage from glial cells or neurons like S100B or GFAP. You have interleukins, you have cytokines, you have a lot of imaging, and the only message I have in this slide is you have to use it time dependent, because some biomarkers are valuable at the moment of injury or shortly thereafter. Some biomarkers can only be, most high level is directly after injury, some have just an increase, so you have to use them in line of recovery. You have to realize that. So diagnoses are time dependent. So we have already changed the outcome in more figures, but still we also have to look at more pathophysiological mechanisms which can add to prediction of outcome. And this one I made myself to a little bit explain how you see the patients. I just talk you through it, because another thing which is a challenge is personalized treatment. Most of the time there's an accident, and normally you have complaints and they diminish. That's the normal pattern. But if you see and depending on the complaints, you can identify them and give them an intervention or not. That's a simple model. However, in daily practice, you can encounter patients who have very high complaints. It's not the good recovery pattern you expect to be. And we know from the personality factors that over time, then the psychological factors also have a role in the recovery process. And then the question is what to identify and what kind of intervention to provide. And I think that, for example, if you encounter the patient at this moment, it's quite clear. It's all physical complaints, it's about balance, it's about headache. Okay, then the identification and the intervention is quite clear. If you see the patient at that moment, maybe some psychological factors are involved. Or even at a later moment, here or even after a year or later, then also you really have to look at more at psychological factors. So for the patients, the complaints are the same, even worse, but as a care provider, you have to realize at which moment you encounter the patient and what kind of factors are really important at the moment you see the patient. So that's what I thought I can visualize it a little bit better. So that's about the moment you see the patient. The other thing is, I think you have to choose for some kind of two-step approach. You have to, because a lot of people recover well. I do not want to see everybody who has a mild TBI back at the outpatient clinic. It's too much. But I want to see those patients who have a risk for unfavorable recovery. And you have some factors you can already identify at the emergency department. In the weeks thereafter about personality factors. And I think if at that moment you see that at-risk patients and you can do some symptom profiling to look at which symptom is now really prevalent, it's about physical complaints, is it about cognition or behavior, then maybe you can provide targeted therapy. So I think that's the way we have to go forward. And then if that does not help, then you can provide them psychological treatment and extensive multidisciplinary treatment at a later stage. But I think the first part of patients, I hope they will respond at early treatment. That would be my idea how to proceed research. So to summarize, which, when, how to treat. There's an identification window and an intervention window which can change. You look at several factors, at injury and demographics, personality factors, biomarkers, but you have to realize that injury is multifactorial, outcome is multidimensional, and diagnostics are time dependent. So you really have to be aware of all those factors talking about treatment and of mild TBI. So that is the end of my talk. Some take-home messages. Both severity and injury and personality factors are important. Brain networks collaborate at least temporarily, less efficient. Outcome is multidimensional, which you already know, of course. Be aware of age in elderly and explore the role of inflammation. And that's the end of my talk, and maybe you have some questions.
Thank you so much. It was really interesting. What about the severity of symptoms that people today experience? Is it a lot more severe than maybe 20 years ago?
It's about time trends then.
No, I'm thinking, what is it in our? Of course, we have some, ideas of what it's about. But what are your explanations that if it's the same thing you see in Holland, that people are more severely and are.
Yeah, well, that's a little bit speculative, of course, because nowadays I see more patients in the outpatient clinic who wear sunglasses and who wear earphones. I did not see them 10 years ago, so that's peculiar. I see less people with whiplash injury. Whiplash injury. Yeah, whiplash-associated disorder. But we knew already, so it learns you that I think there are some trends in recognition of symptoms and diseases, and maybe also symptoms are related to the time in which you experience them. And regarding whiplash-associated disorder, there are no whiplash-associated disorders in Litouwen, for example. And there are in the Netherlands. That's funny. That's funny. So it's also about how it's part of awareness, about information, maybe about liquidation, I don't know. That's one thing. But the other thing about symptoms, it's interesting. And I already said it's about brain filtering. It's about brain filtering. It's also modulated by emotional distress. People, you could speculate on that, I'm not sure, but the fact that there are much more complaints people have, it's all, and the most important complaint is about stimuli. So they really experience there are too much stimuli. It's about light, it's about noise, it's about tasks, as if they are almost anxious that each stimuli could make them much worse. Noah Silverberg talks about cogniphobia, that it's a kind of fear avoidance model, that you are functioning on such a high level that the balance is that delicate that just one mild head injury can make that balance collapse. And then, and people experience that by they already functioning. You have to react on all that stimuli on the phone and in the world and whatever, and then they get a TBI, and then for them the most important complaint is that they cannot handle all those stimuli. That's what I think from an empirical point of view, and not research but I think something. So you really have to consider that as a severe complaint from current society. But it is a complaint, and all what I've said still counts for recovery. Yeah.
Okay, I was considering that most of these prediction models, also your own from 2017, they kind of have a performance around the fair, and also around a few ones in a good direction.
Yeah.
Which also means that we are not at an excellent all point.
No.
And also the say that we early on can say with a certain kind of, with a certain, with not complete certainty,
No.
who's going to develop these long-standing symptoms and who's not. And
Yeah.
I think also about the ethics in this position, where we say you should probably, but again, maybe you're going to have something or not.
I'm not sure. I think it's an interesting question because over the years it has not much improved. So from big studies like the center TBI, the tract TBI, now the belief is that if we add those biomarkers, then the model will be perfect. Well, it's not the case, of course, because, and especially in mild TBI, I think, because if you really think that personality factors are also important, and these are also related to each other, because we now talk about coping, but coping is also related to emotional distress and to resilience, and every patient has his own balance. So I wonder, you can have some markers of structural damage, for example, or functional damage within the diagnostic part, you can add it. But the interplay of the structural damage with personality factors is that delicate, so I'm not sure whether you can really add them to the prediction model. So that's why I think you have to identify a patient at risk, and further on you have to look at the patient, which kind of profile the patient has, but maybe you cannot fit it really into a prediction model. I'm not sure about it. And then I did not even talk about the outcome factors we use. So I don't think that always this prediction model is the big solution. No. Maybe that's the answer you appreciate, yeah.
I was just wondering, you mentioned these studies with the concussion in hockey players.
Yeah.
You also mentioned at-risk patients in your own clinic. Do you see anything with patients that have a concussion for the second or third or fourth time?
Yeah, well, there are some studies who find that if you have more contusions or TBIs, then there is an association with less favorable outcome. And there's discussion about the earlier you have them, maybe there is also an age factor, which the younger the brain, the more vulnerable it is. So there are studies about that. And the other thing is about subconcussive impacts, which is about a lot of subconcussive impacts. And that is more related to sport injury, and also, of course, about age and at what age are you more vulnerable. For example, in the Netherlands, there's a lot of discussion about soccer and heating, because is heating now really that dangerous? So there is now research going on, we don't know it. So I think there is an association, but still, as a neurologist, I also think you have a protection from the skull. So you have to really be aware of the fact that a head injury with bumping your head towards some object and having a brain injury with loss of consciousness and, for example, PTA, you really have to be critical about, is there a difference? And to be careful to say, I have bumped 3 times my head, now I have a recurrent head injury, and that's the explanation for having complaints. So you have to be really careful about the interpretation of those things.
Yes. I'd like to ask you about your thoughts about elderly people, that 1 in 4 with TBI is a person about the age of 60 years. But I'd like to know about the research in long-term effects and recovery. What does it say about the difference between people about the age of 60 and the young people beneath the age of 30?
Well, we are now we have just closed our study, so we did not really analyze it. But you could imagine that, for example, in elderly people, they have already some kind of impairments. So the pre-injury functional state is most of the time not that optimal. So you could imagine that if they have a mild TBI, that the functional state is not that important. It's about other qualities of life. So maybe people that are older, if they are 70 or 80, have other needs. Their need is not to be to doing all the things in society, but maybe they want to be part of social activities once a week or twice a week. So I think elderly have other needs, for example. They also have other social circumstances. Another point of elderly, which is a difficult part, is the cognitive reserve, because in that study we did, we realized that if they really were cognitive impaired, they could not be part of the study. So we lost some patients. But also elderly people have more sicknesses. So we included around 190, but we lost some people because they got some other diseases, or they got cognitive impaired during follow-up. So it's also about cognition and about how aware are they of their impairments or of the cognitive impairments. So we also included a list in which the family members are asked how they think their close relative functions, because you could doubt maybe if they always have a realistic picture of their functioning. So, and those are all aspects. And we also found, for example, that we compared it in the upfront, the groups, and we found more in the quality of life study, and then we found that younger people are more hampered by their passive coping style, and we did not find it in elderly people. So maybe they also use other coping styles.
Well, then I take the liberty to ask the last question, Joukje, before our break. So you conclude your presentation by talking about precision medicine and personalized medicine, and suggesting, at least within the research field, that we should be aware of the multifactorial nature of the injury, and look at multidimensional outcomes, and be very aware of the time when we are actually seeing the patient. Yet also we do have windows of opportunity in the early phase where we can target the symptoms and go for very specific treatments. So this is all going on in the research field. It's not really anything that we see being implemented in the practice as yet. Would you think that it is still too early, or are we there where we should try to influence the clinical practicing decision makers to go ahead and establish or change the way that we are running the field of mild traumatic brain injury? In general, these patients, as you also said, they are being sent at home, and that's it. And only if they develop long-term symptoms, and usually also quite a long time after that, they will eventually return to the healthcare system.
Yeah, I really think that it is important to identify them earlier, but we cannot see all the patients with mild TBI, so really we have to identify the at-risk patients. Also, and you have to involve the general practitioners, which is quite difficult, because for general practitioners they say, well, from all the patients I see a few per year, and I'll see them when they have persistent complaints. But the discussion is, of course, if you want to identify them early, it would be nice, you can give them a call from the hospital, but they could also get a call from the general practitioner. So, currently, we are discussing about guidelines about acute care of mild TBI in the Netherlands from the first 3 months. And we have discussion about two things with the general practitioners. It's about when can they send a patient to the hospital in the acute phase, and when we can send a patient to the hospital in case of persistent complaints. And we aim to make that guideline the same for general practitioners as for neurologists. But there's a lot of discussion, because neurologists also do not want to see every patient, But general practitioners want to have information to know when can I send patients to the hospital. And so I think the answer is, yes, we really have to be more aware of the fact that if we want to see them, we want to see them more earlier, because we can provide an intervention which is much cheaper than a treatment for weeks at a long term. But because there are all those people involved who only look at a patient in time, you really have to connect them in care. And it's just an ongoing process which has just started, I think.
I guess on that note, thank you very much for your excellent talk.
Yeah, thank you.